Thank you, everyone, for joining us for another Learning Lunch hosted by FormatApproved.com. My name is Brian Johnson. I'm the Senior Director of Online Education with Format Approved, and I'll be your moderator today. Today's Learning Lunch will cover deadline looming for HIPAA compliance. Are you ready? We're joined today by Mike Semel of Semel Consulting. Mike is one of the top HIPAA experts in the country, and we work closely with him as partners here at Format Approved. You literally could not find a better resource on HIPAA matters, so hold on to your hats and have your questions ready. Along those lines, some housekeeping notes. Please note that you can ask questions of our presenter at any time during today's session by entering them into the chat area during the presentation. In the second half of our session, we will address as many questions as time allows. If we do run out of time, answers to all submitted questions will be posted to our website and sent by email link later in the week. Also, please note that all registered attendees of today's session will receive an email with links to both the recorded and PDF versions of the event. So people often ask us during the presentation if they can get the slides, and rest assured we will send those out to you following the event. All right, Mike, well, first of all, thank you for joining us today. It's always a pleasure.
Hi, Brian. Thanks for having me.
All right, well, let's just get right into it. We've got only, 5-6 days left before the Omnibus final deadline. Tell us a little bit about why we're seeing such a changed environment for HIPAA compliance.
Well, Brian, it's a combination of things. First of all, if you go back to when HIPAA was written, it was the rules themselves were for the privacy and the security part for electronic data go back to about the year 2000. And if you think back to that environment, we didn't have a lot of internet bandwidth. We didn't have solutions that were being provided through the cloud, which would be provided by a company that's hosting servers and programs that you access through the internet. We didn't have things like online backup simply because our old modems and DSL connections didn't support the transfer of data at the level that would allow that to happen. So the rules themselves weren't written for what we're doing today. The other thing is that over time, the rules that were in place really weren't being enforced. So from in 2003, the HIPAA privacy rule came in 2005, the HIPAA security rule came in, and for the next few years, there wasn't a lot of enforcement. The Inspector General for the U.S. Department of Health and Human Services wrote a scathing report saying that CMS, the Centers for Medicare and Medicaid Services, were not enforcing HIPAA at the level that it should. CMS had a pretty strong argument that they were not given any extra money or enough funding to enforce HIPAA. So when the HITECH Act came out in 2009, it, number one, moved the enforcement to the Office for Civil Rights, which is another department within Health and Human Services. It also funded enforcement. And one of the first things they did with the money was hire a former federal prosecutor to be the director of the Office for Civil Rights. And that sent a clear message that they were serious about enforcing HIPAA as opposed to hiring some other type of bureaucrat. This person's a prosecutor. The HITECH Act authorized state attorneys general to enforce the HIPAA civil penalties. So overnight, you went from having one enforcement agency, OCR, the Office for Civil Rights at the federal level, to now having 51 if you add the state attorneys general. The U.S. Justice Department is the organization that handles the criminal prosecutions for HIPAA. So we're talking about the civil ones. OCR is allowed to keep the fines that it collects, and they changed the data breach law so that it now says the penalties can exceed $1.5 million, and they took out some of the loopholes that were used in the past to avoid having to report data loss.
Well, that's certainly interesting. I didn't realize in the past that OCR is allowed to keep the fines it collects, so it's almost like the DEA or something. Whatever cash they find on you, they're just going to take it. I mean, it's not quite like that, but there is that kind of same forfeiture, so they're really incentivized to enforce.
Right. And I won't ask how you know that, Brian.
Former life. All right, well, let's move on. What in the world is an Omnibus Final Rule, and why is everyone talking about it, and why does September 23rd matter?
Okay. Well, in any sort of law that's called omnibus simply means it has a lot of different parts to it. It's not just a very focused law. So the HIPAA Omnibus Final Rule is a modification to the original HIPAA regulations that, as I said, go back to 2003 and 2005. And the modification, the Omnibus Rule just by itself is 562 pages. So it's very broad, and it's also got a lot of detail within those sections. And why September 23rd matters has to do with how the government enacts laws and implements rules. So the HIPAA Act of 2009 is the law itself that was passed by Congress as part of the ARA money, the stimulus funding. The ARA funding was the American Recovery and Reinvestment Act, and you've seen a lot of different projects around the country, but that funding was part of the HIPAA Act. The HIPAA funding was out of the HIPAA Act, and what that did was fund the Electronic Health Records Incentive Program, which is the meaningful use program that medical organizations, providers, and hospitals are taking advantage of to get some incentive money to implement electronic health records. It also funded the HIPAA enforcement that we were just talking about. So the way the government works is that a law is passed, and then the agency that has to enforce that law has to write the rules. So the rule, there was an interim rule back in 2009, and then it took until January of this year before the official final rule came out. That's the one known as the HIPAA Omnibus Final Rule. It was announced towards the end of January, and then it went into effect in March. And from the March date, they gave a 180-day moratorium on enforcement to give people time to comply with the rule. So that date is September 23rd, this coming Monday. So everyone that has been complaining about how little time they've had to do this, the government has been saying a couple things. One is that you knew back in 2009 from the law that business associates were going to have to comply. We knew that. We've been talking about this for a couple of years and talking to groups of speaking at conferences where we've been speaking, saying that you're going to have to comply. We're just waiting for the rules to come out with the details. That's the rule that came out in January, and then they gave 6 months for everyone to comply. The other thing the government said is that business associates have been business associates for years. You actually have been a business associate if you've been providing a lot of the types of services that qualify going all the way back to 2005, and you should have been following some of these rules anyway. So what's happening now is that business associates have to sign business associate agreements. So we deal with a lot of business associates and also healthcare organizations that have not done a good job and been diligent about having all of their vendors sign agreements. If they're signing an agreement now, it has to have the new terminology. So back in January 25th, the government published new terminology for business associate agreements, and that's the terminology that needs to be in a new agreement. Where it says on the slide replacements by September 22nd of 2014 is the government giving organizations that have had existing business associate agreements in place, for example, going back to 2005, they've got another year to replace the paperwork. It doesn't mean that their business associates don't have to comply now. It just means that they have until 2014 to replace the existing business associate agreements with those that have the new lingo. You have to implement, a business associate has to implement a full compliance program. That means policies and procedures, training the workforce, have to perform and document HIPAA compliance tasks. Again, from the government standpoint, they should have been doing this since 2005. And now there's additional guidance on managing subcontractors. We're going to talk about that more in detail later. But the problem with business associates and the relationships with covered entities and all these agreements and things is not a legal exercise in paperwork. In other words, you have to sign the business associate agreements, and if a healthcare organization shares information with a vendor, like an IT company, for example, and does not have a business associate agreement, it's actually a violation for the healthcare provider, not the IT company, because the provider or the covered entity has the responsibility to sign them with the downstream business associate. Business associates will now have the responsibility to manage their subcontractors and have those agreements. The compliance is by what you're doing, not whether you have the paper in hand. So that says compliance by act, not contract. If an IT company is supporting a healthcare organization, they're a business associate with or without a contract. If they're using an online backup company, for example, that online backup company is a business associate, even if they don't have an agreement with the business associate or with the company that's reselling their service. So it's compliance by the act, not the contract.
I think that's a great point, because we hear fairly often people say, well, I've got my business associate agreement, so I'm done. But that it completely misunderstands the law, the regulations. It's really not the point. The point is to be compliant, not just to have some piece of paper. I think that's an important point.
Well, and Brian, likewise, I've heard the opposite, where, well, we're not going to sign a business associate agreement, so that means we're not a business associate. And that's
right. Right.
If they're providing the service that makes them a business associate, with or without a contract, they're a business associate.
Yes, so you don't just get to opt out of being a business associate. You either are one or you're not. And I want to circle back around and say I think it's an important point, too, that, business associates should have been compliant some time ago. The rule, there's new things in the rule, and there's clarification about who's a business associate, but most folks should have already had compliance programs anyway.
Right.
Well, you may not know this, Mike, but I have a small medical practice on the side. And as a doctor, I'm really relieved to hear that the Omnibus Final Rule doesn't even affect me. Is that correct?
Not correct, Brian. So, as a doctor, and assuming you bill electronically for healthcare services, which makes you a HIPAA-covered entity, you have to sign business associate agreements with anyone who's not on your workforce that has access to protected health information. So some of those organizations, we'll have a list soon, but it could be a shredding company, it could be an IT company. We'll talk about that in more detail later. But you have to have those agreements, because otherwise the information that you're sharing could be a data breach, and certainly would be a HIPAA violation if you shared it even with someone that was a business associate and was compliant, but you didn't have the agreement in place. The next line refers to NPP, which is a Notice of Privacy Practices. The new Omnibus Rule has made some changes to the information that goes into NPPs. It's changed the patient's right to access certain information. It's put some restrictions on healthcare providers using patient contact information, for example, for marketing. So new NPPs are required. There's some different resources where you can get them, but the new NPPs have to be given to new patients, and you get the acknowledgement just like you did in the past. The other thing about NPPs is you don't have to send them out to all of your existing patients. Your current patients don't need to get new ones, but the law says, or the rule says, that you have to make them available. So, for example, post the new one in the office and have a little holder like a brochure rack that would have your new Notice of Privacy Practices in the waiting room. That way your current patients could come in for a visit and pick up the new ones. If you're a health plan, you have to send the new ones out in your next annual mailing. So these are some big effects. The changes to patient record release has to do with electronic records. So a lot of healthcare providers have policies on what they charge per page, for example, to make a copy of a patient record for release to the patient or someone the patient designates. The new rule says that with electronic records, number one, the patient's allowed to request the record electronically. You have to give it to them in a format they can read. So it's in an EMR system or an electronic health record system. They obviously don't have that, so you have to be able to give it to them in a format like PDF or some other way that they can read it. And the new rule says that you're not allowed to charge for that, but you are allowed to recover costs. And the difference between charging and recovering costs would be you can't say we're going to charge you X amount of dollars per page or whatever to recover costs. If you had an employee that you were paying $20 an hour to, and it took that person 15 minutes to export the patient record and get it on something to give to the patient or send it by email, then you could recover the 15 minutes of cost, which would be $5. You could also recover, for example, the cost of media if it was like a thumb drive or something that you were going to hand it to them on. But you're not allowed to just say we charge X amount of dollars for a patient record. You're allowed to recover costs now. The HIPAA changes require that your policies and procedures, which are a requirement of HIPAA, must be updated to conform with the new HIPAA Omnibus Final Rule. Same thing with training and awareness programs. You have to have a risk analysis. That's literally the first requirement of the HIPAA security rule, which has about 50 different requirements in it. Number one is a risk analysis. And there's also a risk analysis that's required for meaningful use. It's a little bit different than a HIPAA risk analysis, but this is another area where doctors have said, why do I have to have one now? And our answer has been, you should have had one since 2005. It was a little vague at the beginning how often a risk analysis needed to be done or updated. The rules that have been enforced have really come out with the requirement that a risk analysis needs to be completed or reviewed on an annual basis and changed when anything significant changes to the environment. So a risk analysis from 2005 is not acceptable today. It also probably wouldn't have current information about your computing environment and so forth. It also doesn't mean you have to rewrite one from scratch every year. You simply could pull up last year's and review it and note that you reviewed it and there were no changes required. You have to update them more often than once a year if something significant changes. So if, for example, you had a server at your office and you had it moved to a data center that's going to provide better security, then you need to have a new risk analysis because your environment changed significantly and your current risk analysis wouldn't recognize that. So Brian, as much as you'd like to hear that the Omnibus Rule doesn't affect you, it affects you in a lot of different ways.
Well, that's clear. Well, here's a follow-up question. Here are my little medical practice that I've got going, which is, of course, you know, there's going to be hundreds of lawsuits, I'm sure. Our HIPAA policies here are only a page long, so that'll be pretty easy to update. Is there anything I need to be aware of in updating that one page of HIPAA policies?
I think so, and here's why. First of all, a HIPAA policy that you hand to your employees so that they understand what they have to do and what they shouldn't do could only be a page, because it's going to give them some do's and don'ts, and that's the employee-facing policy. The problem is that if you're audited or investigated and you handed a one-page policy to the auditor, they're going to look at that and tell you probably have not complied with HIPAA because HIPAA has so many details in so many different areas, in some cases that don't affect employees and affect employee behavior, but your one-page policy simply does not have the detail necessary to prove compliance with HIPAA. So let's go back to the risk analysis we were talking about. The organization needs to have that risk analysis done. And first of all, it has to be completed, it has to be reviewed at least once a year, and it has to be updated as needed. You should have a policy that says that. That's not a policy you would hand to a receptionist, for example, on what the receptionist needs to do to keep patient information private. That's an organizational policy that shows that your organization is going to commit to HIPAA compliance. So I look at policies from the standpoint of think like an auditor, that if someone came in and said, here are the 50 sections of the HIPAA security rule, show me your policies to conform with those 50 sections, how could you possibly fit that into one page? And how could you possibly have a document that you would only give to your employees that show what the organizational policies are for, say, workforce clearance, that you're going to do a background check or you're going to check for licenses before you're going to give a nurse or a doctor access to your patient information? Those are the types of policies that are required. The policies that Format Approved offers are more than 130 pages. Now, we don't suggest giving those to the employees because that's too much detail and there are policies in there that they don't need to be aware of and that don't affect their jobs directly. But my point is that when we write policies, we're writing them from the standpoint that we want them to comply with HIPAA and sustain an audit. So every policy that we've written is specific to a HIPAA regulation. It's not a general policy, for example, on privacy or security. It refers to the CFR section, which is the Code of Federal Regulations. So when you see 164.308A1, that may not mean much to you, but to a HIPAA auditor, they will understand exactly how that policy links back to HIPAA. We use similar language to HIPAA. When HIPAA says you must protect your devices against malicious software, we write a policy that said our organization will protect our devices against malicious software. There again, it ties back, and we don't have to spend a lot of time trying to explain to an auditor how our policy that says our organization will protect data, period, somehow means we're doing all the specific things that HIPAA requires. In our policies, we don't include procedures. This is a huge failing I've seen of organizations that write policies and incorporate procedures, and then over time, the procedures go away, but they're still listed in the policies. That creates a couple of problems. One is that the new procedures haven't been added, so you're doing things that aren't in the policies. The other thing is, from a technical standpoint, by retiring an old procedure and not changing the policy, you could actually be considered in violation of the policy. So in one hospital where we did an assessment, they had a reference in their policy to an IBM System 36 computer and how often they were backing it up. And I asked if they still use that because it's not something we've seen very often lately. And they said, oh no, we retired that computer years ago. They have a policy that they're going to back it up every night. So by retiring it and not backing up, technically they're in violation of the policy. Where that could become a big deal is if you fired someone for violating a policy and they got a copy of all your policies and found out that you weren't complying with them, that may be a case for them to claim discrimination and cause other problems. The bottom line is we separate policies from the procedures that we use to support those policies. Procedures and training are what you have to do over and over again to make sure that your staff is doing the right things so that you comply with HIPAA. And it's an ongoing challenge, and HIPAA requires that you continue to do that. So not just having policies and procedures, but training your staff and also having reminders on a regular basis so that they don't forget that they have to follow these steps.
So we've been talking about business associates but also covered entities, but in that business associate realm, who exactly qualifies as a business associate?
Well, the first answer to your question, Brian, is who doesn't. So who doesn't qualify is another covered entity. So if you are a doctor and you're referring a patient to another doctor, you don't need a business associate relationship with the other doctor because you're both covered entities and you're allowed to share the information, the patient information, with another entity, another covered entity for the purposes of treatment, payment, or healthcare operations. So now who does qualify? It's someone who's not in your workforce that comes in contact with PHI, which is protected health information in any format. It could be verbal, it could be electronic, or it could be written. And then ePHI is the specific reference to electronic protected health information. Some business associates under the new rules only maintain data even though they don't access it. That's brought in a whole new group of business associates and subcontractors which are data centers, online backup companies, cloud vendors, organizations that hate the idea that they have to comply with HIPAA because they have implemented security that says their people can't access the data, but under the new law, that doesn't matter. If the data is encrypted, if it's in locked racks, if they can't get to it, they're still maintaining it in their facility and they're responsible for it. So the examples here, and these are companies, there's a lot of reasons why these companies have access to data. IT service providers, copier repair companies. You don't think of your copier as a computer, but it does have a hard drive in it, and the hard drive keeps images of the documents. And recently there was a fine of $1.2 million to a health plan in New York City that had returned some copiers after lease. And you may be familiar with this because CBS News bought one of the copiers, got all the patient data off of it, and made this a segment on 60 Minutes. So copier repair companies, shredding companies, document storage companies, paper storage. So if you have a warehouse that is picking up the boxes with patient records to store them for long-term retention, they're now covered because they maintain the data even if they don't look at it. Attorneys that represent covered entities in CPAI. So if an attorney is representing a doctor or a hospital, for example, in a healthcare malpractice suit, and they see healthcare information, they have to comply as a business associate. If an accountant is auditing a covered entity, and they see protected health information, so if they're going to track a bill and see that the patient made their copay and that the insurance company paid its share, and then perhaps something got written off because of the insurance company discounts, they're going to trace that transaction through the accounting process, and they're going to have to be looking at PHI to see that. So an accountant can be a business associate. Collections agencies, answering services. This one seems to be forgotten by a lot of healthcare providers, but their answering services are taking messages from patients and from other doctors and from hospitals, and they're handling PHI all the time. Temp agencies. So a temp agency could supply someone that's a healthcare professional. Recently I was at a healthcare organization that had hired some temps to come in and scan the medical records and take them from being paper into electronic format. They were knee-deep in protected health information. EHR companies. We talked about the data centers and the online backup companies and the cloud vendors. Insurance agents. Now the insurance companies, the underwriters, are the payers in the healthcare system, so they're considered covered entities, but an insurance agent that's selling health insurance and collecting medical information, or life insurance and collecting medical information, now is an agent for a covered entity. There are companies that do things like revenue cycle management, where they may analyze, for example, bills that are going to insurance companies and advising a healthcare provider what they can do to change the coding to perhaps get more revenue from the services. And what they would do is they would take a particular type of treatment and look at all the different codes that would be possible to bill for, and they may see that you haven't billed for all those. That's the type of company that may look at your medical records, even though they're not part of your workforce. And then you have people like transcriptionists that don't work for your organization, and you may contract with a service or with an individual to do that. They're all business associates. They all have to sign business associate agreements, and they all have to comply with HIPAA.
So here's a question that I hear from folks fairly often, and I'm sure you may hear it as well. You know, do we have to make such a big deal about all of this? Can't an organization just sit down with a checklist, and if they follow the checklist, then they're HIPAA compliant? What's the problem with that?
Well, first of all, I think checklists are good ideas, and we use them all the time for the things that we do. But the problem with just using a checklist is that you have to really follow it and be able, at the end of the day, to sustain an audit or a data breach investigation. My problem, and I run into this every day when we work with healthcare providers, IT companies, people that are either covered entities or business associates, is that when we take our questions that we'll ask as part of our checklist. For example, for a risk analysis, many times the clients don't understand the questions, and we'll have to explain them a couple different ways or give them examples, and then they'll get it and give us the answer that we need. A lot of times they don't understand the underlying technology, but they'll still answer a question, and we'll rephrase it, and they'll say something like, you'll have to talk to our IT guy or talk to our IT solution provider if it's an outsourced company to get the answer to that. So my problem with checklists is that I've done many, many risk assessments and HIPAA compliance assessments for the last 10 years, and in some cases people have had checklists that were done, and we've gone through, and 80% of their answers have turned out to be wrong. And it's not saying they're lying, it's saying that they may not have understood the question, or they may not have understood the underlying technology and so forth. So they're putting the wrong answer down, and the challenge is that if they were audited or if there was a data breach investigation, they wouldn't pass. So the government, and this was some guidance that actually came out of the Meaningful Use Core Measure 15, which is the security risk analysis for meaningful use. The question was, can we do our own risk analysis? And the government says, well, yeah, you can, but doing the thorough and professional risk analysis that will stand up to a compliance review will require expert knowledge that could be obtained through services of an experienced outside professional. So the government's pretty strong in saying you really need to know this stuff in order to be able to do a thorough risk analysis, which is, as I said, the first requirement of HIPAA. And that's where we think that people just getting checklists are not going to be compliant at the level they need to be. In the same guidance about the meaningful use risk analysis, security risk analysis, there's a specific question. Can we just use a checklist for our risk analysis? And the government says no. So this is something where we're not saying that people, that checklists themselves are bad. We're saying that it really has not been successful in making people compliant at the level that would sustain an audit or a data breach investigation.
So what's the worst that could happen here?
Well, the worst that could happen, and we're showing some fines and things on here, but the worst that could happen is that it could affect your practice or your business in a huge way. Something that's not on here are some of the data breaches that have occurred that have really caused a lot of cost and embarrassment for healthcare organizations and also their vendors. So back in towards the end of 2012, there's a company called Omnicell that makes drug dispensing carts, and they had some sort of a software problem or whatever where one of their field technicians had gone around to 3 different healthcare organizations and downloaded patient data, and it ended up on an unencrypted laptop. The laptop was stolen, and 68,000 patient records were breached, and each one of those healthcare organizations had press conferences or sent out press releases that said they were disappointed in their vendor because Omnicell had signed contracts that said they would only store data on encrypted devices. If the device had been encrypted, not only would the data have been inaccessible, it wouldn't have been a reportable data breach. That's one of the situations. About 2 months ago, in the middle of July, there was a burglary in Chicago at an Advocate Healthcare doctor's office, a medical office. 4 computers, just desktop computers, were taken, and they reported, within the reporting period, they self-reported that 4 million patient records were lost, and those 4 million patient records included Social Security numbers. So we haven't seen a fine yet, but they've already announced that they're offering credit monitoring services to those patients. So if you take, I don't know exactly what credit monitoring service costs, but I'm going to guess at the lowest end with the biggest discount it may be $25 a year. I have no idea. Maybe it's $100 a year. But at $25 a year, if you do the math, that's $100 million just for credit monitoring services. There may be other costs. There's already a class action lawsuit, so they're going to have to defend themselves. And the federal government is investigating this. And if you go back to what we said about the High-Tech Act authorizing attorneys general, the Illinois Attorney General is also investigating it. Just imagine what the costs are, let alone to the lost trust that people may have in advocates and what business that may cost them. So they're paying for credit monitoring. They've got their lawyers defending themselves in a class action lawsuit. They have to deal with a federal and a state investigation by the attorneys general. So this is very serious. So what's the worst that can happen? These are examples of actual fines and penalties for HIPAA violations. $50,000 for a lost laptop for a small hospice. I believe there were 300 records on that laptop. $100,000 in Arizona for a 5-doctor practice, and that's because they were using Gmail and a Google Online Calendar for patient information. And Gmail is not acceptable for HIPAA because Google will not sign a business associate agreement. Google's terms and conditions to get your Gmail account say that they can access your mail. So it's a violation to have any patient information going through Google Mail, and this practice paid $100,000 for that. Idaho State University paid $400,000 when a firewall failed, and it wasn't caught for 10 months, and 17,000 patient records were breached. We already mentioned when we were talking about the hard drives on copiers that Affinity Health Plans just paid $1.2 million because of their copiers going back with patient data still on them. And I doubt that anybody at Affinity Healthcare or Affinity Health Plan, until the 60 Minutes piece came out, even knew that there were hard drives in their copiers. And recently, I did a risk analysis where I asked the healthcare organization if their copiers had hard drives in them, and they said no. I said, please provide me with the model numbers, and I went and found out that 2 of their copiers had hard drives in. So they didn't even know it. That's a risk, because if someone comes to repair your copier and the hard drive has to be replaced, then they may walk out with the bad one that still has patient information on it. Mass Ioneer Hospital had a doctor traveling. His laptop was stolen, $1.5 million penalty. And a technician at the Alaska State Health Department lost a backup drive, and they paid $1.7 million. The government has gone on record as saying this year, after the September 23rd deadline, there will be a lot of enforcement actions, and there's a lot of pent-up demand because they've not been able to go to business associates and penalize them in the past. And just because the business associates can be penalized, it doesn't mean the practice is off the hook. If your business associate did something wrong and breached data, you are responsible for that, and you could also be fined.
So there's not much time left before the deadline, and I think many people are trying to scramble to get ready. What are just some immediate things people can do to be more compliant than they are now?
Well, I always say to start complying, stop doing the things you shouldn't be doing. So you start complying by stopping things. It's just like if someone's been injured, you stop the bleeding. If you're using an unsecure email system, you need to stop doing that. If you're texting patient information to your practitioners and they're using one of the cell phone services, the text messaging services, in other words, one that's not secure, then you need to just stop doing it. People have secure email systems in their offices, and then they'll set up their smartphones to synchronize mail, which is really convenient. But if that smartphone gets lost, that means that patient data is going to get lost. You have to stop doing it and either secure the phones or stop doing it at all. You need to stop sharing passwords. HIPAA requires unique user identification, so people can't log into a computer and have 10 people sharing that computer all day without putting their own credentials in. And stop trying to secure patient data if you're not a security expert. I see this a lot where people have tried to do things, or they want to hire their relative or a friend that knows a little bit more about computers than they do. With these new rules, your data has to be secure and protected, and you need people that really understand what they're doing to do that.
So we've discussed some of this, but what should organizations have in place by September 23rd? What are they supposed to have?
Well, we've already talked about a lot of these things. Notices of privacy practices. So if you haven't gotten a new one out, you have to get a new one out, and after September 23rd, if you're using an old one, you're not in compliance. If you've got business associates and they haven't signed agreements, and if their subcontractors haven't signed agreements, then your business associates aren't in compliance. You need to have updated HIPAA policies and procedures. You need to have had your workforce trained. And when it says security officers, we're talking specifically about the people that are responsible for HIPAA, that you want them to understand HIPAA and understand how to manage a HIPAA compliance environment. Your workforce members don't need that. A receptionist, for example, doesn't need to know how to report an incident to the federal government. The security officer does. So there's some different levels of training. And then you need to have a professional risk analysis, and we recommend a network vulnerability test. The problem is, how do you do all those things by September 23rd?
Right, so can people just kind of scramble around with their hair on fire and get everything done by Monday?
If you try to do that, or if you try to make it look like you did, you're not going to have a compliance program that's going to sustain any sort of scrutiny. So my suggestion is, going back to healthcare terms, triage what you need to get done, and let's do the things that are possible. Show good faith at this point. If you haven't done anything, the best thing you can do is show good faith that you're attempting to start some things. And my feeling, based on 10 years of experience with HIPAA, is that if you try it yourself and try to go out and start looking on the internet or getting information and building something from scratch, you're simply going to fail. And again, using the medical term, if a patient comes in and they need a treatment and your doctor is not a specialist in that treatment, you're going to refer them to a specialist. I suggest the same thing with compliance.
So what can organizations do then? What are the things that they can, at least make progress on?
Well, I think these are some things that are pretty easy to do and can be done in a short period of time, even between now and Monday. You can send out business associate agreements or contact your vendors and have them come in and make them sign the agreements. If you don't have them in place, you need to get them. And if your vendors refuse to sign an agreement, you're going to need to get another vendor. Anything you send that vendor sees, if they refuse to sign the agreement, you're committing a data breach by letting them maintain data or have access to data. So it's a very serious situation, but it could be done between now and Monday. You could send those out and get them back signed. It's possible. Same thing with policies and procedures. You cannot possibly sit there and start from scratch and write all these policies and procedures that you would need in your practice to comply with HIPAA by yourself between now and Monday, but you can purchase policies and procedures. Same thing for training. Training could be accomplished in most practices between now and Monday. For the security officer, it takes about 6 hours to take the format approved certified HIPAA security professional course. For the workforce members, it takes about an hour per person to do it. So the training could be accomplished. All of these things could be done by Monday, and even if it wasn't 100% complete, at least you're showing that you've made the effort to comply. You can't have a risk analysis done between now and Monday, but if you had one scheduled and you were ever audited, I really think that they would give you the benefit of the doubt if it was scheduled, for example, 30 days out, that you're going to have it done, and at the end of 30 days, if you haven't been audited or if there's been no data breach reported, it will be done anyway, and the records will show it was done after the 23rd, but I don't think that would be considered to be a violation. Network vulnerability test were the same thing. What I'm saying here is that you have to show that you're doing something. So the administrative things are easy. The business associate agreements, written policies and procedures, it's not on here, but having the new notice of privacy practices out, being given to new patients and printed up and in your waiting area, if you're a healthcare provider, That's easy to do by Monday, and getting the training going, if not completed, between now and Monday. So all those things would show good faith.
And good faith obviously counts a great deal, especially when we're in a situation where so many folks haven't done anything. They're not really showing good faith. And so that, just the fact that you've scheduled these things and taken these measures, that already puts you ahead of those folks, to be sure.
Right. And the government doesn't talk about good faith, Brian. They talk about the opposite, which is called willful neglect.
Yeah.
So when you read the enforcement documents, when we went through all those fines, every one of those fines has a government document that talks about the incident that caused the investigation and what the investigation found. And a lot of those investigations and the big fines, the $1 million plus fines, each one has the comment that the person that's being penalized or the entity that's being penalized has been willfully neglectful of HIPAA. That means you knew you were supposed to have to comply and you made a decision not to at some point. You ignored it, or you made a conscious decision, we aren't going to do these things, and that's considered willful neglect. So I think what we're saying on this slide is that if you did these things, you might be able, even if there was a breach and you were investigated, they might consider it to be not willful neglect, which all of us would say is in good faith, that you were doing things to comply, and even so, the breach occurred. That's better than not doing anything.
Right. Sort of the flip side of good faith is bad faith, a.k.a. willful neglect.
Right.
All right. Well, we have a lot of questions from our audience already, and we do have time for those questions. So we'll go ahead and go through them. As I said before, if we don't get to all the questions, and it seems unlikely that we will, we'll send out follow-up answers, written answers. Sometimes people ask very technical questions too during these sessions, which is fine, but we certainly give Mike the option of going back and providing a fuller written response if the question is thorny. Sometimes we get some really involved questions. Also, I just want to say before we get into those that people have already asked about the security training, the CHSP training, the workforce training, the documentation. All of those products are available from Format Approved. Those were written by Mike. We've worked closely with him to provide this training and these services in an online format, and we'll talk about those after we get through the questions. All right, let's go ahead then. We've got a lot of good ones here. The first one is, if one of our physicians provides a talk at a hospital regarding a certain condition, and we send letters to our patients based on a diagnosis code, is that considered marketing?
When you say sending letters to patients, I'm assuming they're invitations to the talk. Is that correct?
I think that's a fair interpretation.
I don't believe so. I think the marketing that they're referring to in the rule has to do, one of the examples I think would be that if you're a surgeon and you're doing some sort of particular type of surgery like a shoulder replacement or a knee replacement or a gastric band, and you took your patient list and sent the patients advertising that said that you were providing this new service and so forth, that would be marketing. But I don't believe that just notifying patients on a list that one of your doctors is talking about, that's going to speak on a particular topic, is considered to be marketing. Now, the one thing I'll qualify that as, going back to that same example of gastric band and knee implants and hip implants and things like that, would be that if it's a sponsored session from that type of organization, and I'm just thinking off the top of my head now, that if you were going to invite people in to talk about gastric band surgery and it was sponsored by the gastric band manufacturer, then that would probably be considered a violation. But if it's just generally talking about something, a condition, diabetes control or something like that, without it being sponsored by a vendor, I don't believe that would be a problem.
Let's move on to our next question, and this is one that's come up before. I think this is a great one. The question is, are some medical device or skin graft companies business associates? And if so, what if they refuse to sign?
Okay, this is a very easy question that has a very long answer. And the reason, it's not my long answer, I'm famous for giving long answers, but this is where I'm talking about the guidance that's out on the HIPAA websites, and it's under frequently asked questions. And it has to do with sharing information with medical implant companies, and I think it would fit into this example. If they're a covered entity, if they bill insurance, then you're allowed to share information with them without having a business associate agreement. They may be a business associate. What I'll do, Brian, in the written response to these questions is I'll put the link to that question, and I can tell you how I've answered it for our clients that ask that question, people that have surgery centers and medical practices where this comes up quite a bit. My answer has been you have to go back to the vendor and ask them for sure what they consider themselves and for some evidence that would support that. Now, the answer to the question about if they won't sign a business associate agreement, you're going to have to make a decision or perhaps involve your lawyer, and there are some attorneys that specialize in HIPAA, to help determine if that organization is a covered entity where you can share the information, or if they're a business associate, or if there's some other reason why you don't have to have a business associate agreement. And there are a few exemptions to having to have business associate agreements. But now you're getting into legal territory and contract territory, which is out of my area of expertise, since I'm not an attorney and I don't give legal advice. But the practical answer to the question is ask them why, if they will refuse to sign a business associate agreement, ask them what's the basis for your being able to share the information with them, and then talk to your attorney.
All right, here's a question about what constitutes PHI is what I think it ultimately gets to, but I'll just read it to you. The question is, would a mailhouse company that processes direct mail or an email company like Constant Contact need a business associate agreement when they are only seeing patient name and address or email address?
No. And the reason for it is what you said at the very end. So let's go back to that underlying question. What is protected health information? Protected health information has to be identifiable, and it has to tie information about a diagnosis or a treatment to the patient name. And the patient, I use the patient name kind of in quotes because there are other identifiers. You can't hide it under their initials or an address or even a patient ID number in your system, because those are all considered to be identifiers. So using that example, if you simply had a list of names and addresses, for example, that in and of itself wouldn't be protected information. Where you might have a problem is if you went out and created an email that said, "Dear diabetes patient," as the email that you're sending through Constant Contact, then I think that might be considered to be a business associate issue, although I've never seen that tested.
Well, that may not be the best email to send regardless of HIPAA, but thank you for that answer. Here's a great question, too, about mobile devices. The question is, if a cell phone is protected by a password, does it count as secured?
No, and for the same reason, the same way it goes for a computer or a tablet or anything else. A password is not encryption. Now, if you're using the term secured kind of in the lower case, where is it better than not having a password at all? The answer is yes, that it's more secured than not having it. So let me explain the difference. I mentioned before, I think, that if a device is encrypted and it's lost, it's not reportable. So if a phone that's protected by a password is lost, but it's not encrypted, that is reportable. And we all know how easy it is to lose a phone. You can also consider other portable devices like the recorders that doctors may use for transcription and other things in a similar way. These small handheld devices could be lost. So a password is secured. I mean, a phone with a password is secured. It's not encrypted. The other thing that can happen is that if that phone is lost, you want to have the ability to wipe it remotely so that if there is email, for example, that has patient information on it on the phone, that you can remotely wipe that and eliminate the data. The problem is that if you don't get the phone back, that still is a reportable data breach.
And just for folks who may not understand the rules around this, if you have encrypted data on the phone and you lose it, if all the data is encrypted, then that's not a reportable breach, correct?
That's correct. Simply putting a password on a phone is not encryption.
All right, well, I'm afraid we're running short on time. We didn't get to all of our questions as I anticipated, but we will send out follow-up answers for those things. So do look for those answers. Before I describe the training and the HIPAA products we can offer to folks, I want to thank Mike for joining us. You know, this is a very busy time for Mike. I was saying to Sarah, one of our associates the other day, that it's like Christmas time for Santa Claus. So we're especially grateful to you for joining us, Mike.
Thank you, Brian. I'm always happy to help.
All right. Well, thank you. And I know that folks out there, this is really useful information for them. I want to thank our audience for joining us as well. The training and the documentation and the risk analysis, those elements that Mike was talking about, those are all available through Format Approved. So if you look at your screen, that first URL, if you click on that when you get the slides or if you type it into your browser, that will take you to our training and certification programs around HIPAA. So we have that CHSP course that includes templates of business associate agreements. It provides all the training you need to be that designated security officer that HIPAA requires. It also has the very affordable, very short, very pragmatic workforce training that people need. You can go in there and dial up as many of those as your staff may need, and we'll get you set up in our learning system. All of our education is entirely online and self-paced, so it's perfect for a crunch situation like the one we're in now. Also, if you look at the second URL there, that will take you to our HIPAA Secure store, where we offer the meaningful use risk analysis, a bundle that includes all of the documentation that a practice would need. It also includes a package that has the risk analysis plus network vulnerability testing, and there's a value bundle in there where you can get all of those things plus some training and really jumpstart your compliance efforts. So do be sure to visit those sites and look at the offerings we have through Format Approved that Mike has helped us to construct. That's really a one-stop shop for your compliance. Again, I'd like to thank our attendees and remind them that all registered attendees will receive an email with links to both the recorded video version of this event, but also the slideshow in PDF form, so look for that. Visit formatapproved.com to learn more about our upcoming Learning Lunches. The Learning Lunch button will take you to our entire slate of upcoming webinars. We've got an interesting program coming over the next month, so do check that out. Our next Learning Lunch will air on September 24th, and we'll cover the subject of patient engagement is an important focus of Meaningful Use Stage 2. So just as there's all kinds of upheaval in the HIPAA universe, Meaningful Use Stage 2 is right around the corner. Keep an eye on your email box and our homepage for other upcoming topics, and thank you again for joining us today.